Thank you, all the attendees and the speakers, for being here tonight to hear about the best of the American Society of Hematology annual meeting on leukemia. This is the outline of today's program. We're going to talk about acute myeloid leukemia, acute lymphoblastic leukemia, myelodysplastic syndrome, and myeloproliferative neoplasms. Then we'll have a wonderful patient story and with Blood Cancer United. And first, I'd like to welcome our first speaker, Dr. Abdul Hay, who's an associate professor in the Department of Medicine, clinical director for the Perlmutter Cancer Center Leukemia Program, and director for the Blood and Marrow Transplantation and Cell Therapy Program. He's interested in early phase clinical trials in acute leukemias with a focus on targeted and novel approaches in AML and ALL. He also has an interest in graft versus host disease prevention and pioneered a novel approach for decreasing the risk of GVHD for haploidentical stem cell transplantation. And so we welcome Dr. Abdul Hay. Please go ahead.
Thank you, Dr. Lahoud. Please, so I want to talk today about three things from ASH because the time is limited. But before I do that, I want to say why it's so important to do more research in AML. So AML is the most common acute leukemia in adults, and unfortunately still have the lowest survival rate of all leukemias. And as you age, you increase the risk of acute leukemia. So if you're above the age of 65, you have 25 per 100,000 risk of developing acute leukemia. So we really need better research and better studies. 5-year survival is somewhere around 30%. In NYU, we have way better survival and outcomes, I think, because we are very aggressive in our research and our transplant. So three things I'm going to talk about. One is was presented actually in the plenary session. It was a phase 2 randomized using high intensity chemotherapy versus low intensity chemo. So conventionally, if someone is fit young, we've been doing for them 7+3 or vicious. This is the first study that compared this with actually patient getting lower intensity like azacitidine and venetoclax. This was presented by Dr. Fathi at the ASH meeting. So patients were randomized 1-to-1, either to get high intensity chemotherapy, that being 7+3 or vicious, and versus azacitidine and venetoclax. Now, something to point, and I think it's very important, is that patients that had core binding factor were excluded, patients with FLT3 were excluded, patients with NPM less than age of 60 were excluded, as well as BCR-ABL fusion or mixed phenotype. So not everyone really got this. So something to keep in mind. And and again, FLT3 is like 30% of AML patient, NPM is 30% of AML patients, so not for every AML patient. So they were randomized, and the idea of the study, we wanted to see if they are similar efficacy. And actually, as I'm going to go through, it's sorted out to be like, no, they're actually one have better efficacy than the other. So the endpoint of the study was clinical activity, overall response rate. Again, the idea was, is this non-inferiority? But it turned out that you have a better outcome, better overall response with azacitidine venetoclax versus high-intensity chemotherapy. In particularly, if you're looking for CR or CRh. Now, for complete remission, there was no difference. But for CR, CRh, or CR incomplete, or even MLFS, there was a benefit for doing low-intensity chemotherapy. Medium event-free survival was 14.6 months versus 5 per 6 months for high-intensity chemotherapy. So there was a significant difference here with 1 year EFS of 53 versus 36. So after adjustment for variable and multivariable model, the effect of aza-ven still was protective for EFS. What was interesting more really than anything else is that more patients were able to go to transplant with the aza-ven compared to people that got high intensity chemotherapy. So there was this transplant has significant protective effect for event-free survival, even after adjusting for variables. So I think that's the take-home message from the study, that you could do low intensity and get by and take patient to transplant. Next slide. So overall survival was not different because patients again were salvaged with transplant or they were able to shift to other modality of treatments. So shifting for early phase. So the first study I present was a phase 2. The second study actually was a preliminary anti-leukemic activity from a phase 1 study, which is a CLN 049. It's a novel anti-FLT3, anti-CD3 bispecific that is for patient with refractory relapse AML or MDS. That study I got the chance to present on behalf of my co-investigator at ASH. So what's CLN-049? It's a novel T-cell engager targeting FLT3 in AML patients. Why it's so compelling? Because FLT3 is expressed more than 80% on AML blasts. You don't need to be mutated. If you just have FLT3, it's more than 80% of AML blasts. And having this novel approach of a bispecific engager where you take your own immune system to fight your leukemia is something of very compelling. And that was one of the studies that we conducted here and led here in NYU. So this is CLN-049. There's animal models showing efficacy before we moved it to phase 1. So we had 45 patients on this study. We started in dose escalation, so we had the dose from 1 up to 12 microgram per kilogram. And you see the majority of the patients were enrolled to 12 microgram per kilogram. Most of these patients are very heavily pretreated. Some had 8 lines before. On average, there were 2 lines at least. And the majority of the patient by far were adverse risk, 84% in the higher cohort. And more than half of the patient had P53 mutation, which we know is a very poor prognostic feature. So what we did see is that the preliminary efficacy data shows that this is a potential achieve actually deep MRD negative responses and actually leukemic activity. So in 8 out of 32 patients treated at treatment dose 6 or above, we achieved CR and CRh. And 3 of these patients were MRD negative by flow cytometry. Again, this is a heavily pretreated, high-risk patient, P53. So anti-leukemic activity independent of baseline genetic risk, including durable responses in T53 mutations. So we had in the highest cohort, 12 microgram per kilogram, we had 4 out of 8 patients, 50% treated at this achieving CR or CRh. Again, this is data for P53 have been extremely poor. This is one of the first studies to show really good efficacy. And they were durable. We had the patient, as we speak now, have been on it for more than 1 year in CR. So 2 things we worry about. One is CRS and associated toxicity. So CRS, we saw 16 out of 45 patients. However, really, we only saw 1 grade 3 CRS. That's it, 1 grade 3 CRS. And once we start doing 2-step up doses, we did not see any grade 3 CRS. And they were all not dose limiting. We saw some neurotoxicity ICANS, 2 patients with grade 1 event that occurred from step-up dose 2 or treatment dose 1, each preceded by grade 2 CRS. Both were transient and reversible. And transaminitis, we saw 3 patients with grade 4 event occurred after treatment dose 1 or 2. And again, they were all asymptomatic, transient, and reversible. So what the take-home message from here is CLN-049 is a monotherapy. In monotherapy, demonstrated promising anti-leukemic activity in a broad, heavily pretreated population of patients with refractory relapsed AML and MDS. At the highest target dose, 12 microgram per kilogram, we had CRR and CRh of 31%. And the majority of responses were actually more than 16 weeks, so you could take them for transplant. And it was safe, safety was favorable, was really no grade 3 CRS and no dose limiting adverse events observed at the highest targeted dose in regimen using 2-step up doses. So because of this data, actually now CLN development will proceed under FDA fast track designation with expansion cohorts planned to start actually as early as next month. So I want to end by just briefly talking about menin inhibitors. So menin was also a big topic in ASH. It's been a big topic for the past 2 years. Why? Because menin is a protein encoded by MEN1 gene. It acts to produce leukemogenesis, especially in 2 mutated AML, KMT2A over an NPM1. And it's a unique subset of leukemias. So it's about 10 to 15% of patients will have KMT2A, but actually MPM up to 30% of patients. And the outcome is not that great. It is about 3 months in KMT2A overall survival. And if someone has therapy-related AML, it's about 1/3 of the cases will be KMT2A mutated. So there were 4, this is my last slide, there were 4 inhibitors actually that were discussed in ASH. Revumenib, ziftomenib, bleximenib, and enzomenib. So revumenib is already FDA approved as well as ziftomenib. So there was some update about them, longer study duration. Bleximenib is one of the menin inhibitor actually we participated in NYU. We still have the study open in NYU. There was some update about the Camelot study, which is for refractory relapsed AML with KMT2A NPM, showing about 1/3 of patients achieving CR. And finally, enzomenib, I'm going to focus on enzomenib because this is the first time we see more data about enzomenib. So enzomenib was a dose escalation. and the best dose they achieved responses was at 300 milligram BID, where they had a CR/CRh of 45.5% in KMT2A mutated patient. Actually, in NPM was way lower, and it seems that it had better efficacy in KMT2A. So that's what. So I just want to summarize quickly that some of the interesting things we saw at ASH were upfront, how we can do less toxic chemotherapy, targeted therapies like BiTEs, which I went over, and menin inhibitor. I think that summarizes most of the interesting things that were done in ASH for AML. Thank you.
Thank you, Dr. Abdul. Hey, great presentation. And the data you presented yourself, I had the fortune of attending. It was truly phenomenal.
Thank you.
So thank you for that. And next, I'd like to welcome Dr. Dimitrios Papaioannou, who is an assistant professor and attending physician in the Division of Hematology Oncology at NYU Langone. He's deeply passionate about hematology, caring for patients with leukemia in particular, which motivates his science, and his research is driven by the desire to develop better and more precise treatments for patients with leukemia. And he's published extensively in the field with more than 30 peer-reviewed manuscripts with sustained focus on molecular drivers of acute leukemia and the role of non-coding RNAs.
Thank you for having me today. As you heard, Dimitris Papaioannou is my name. I'm a physician at NYU Langone Health. I treat patients with blood cancers and also run research programs focused on finding better and more precise treatments for leukemia. And I'd like to share with you some important updates from this year's ASH meeting about another type of leukemia, acute lymphoblastic leukemia, or ALL. What's new, why it matters, and what it might mean for patients. But first of all, what is ALL? So acute lymphoblastic leukemia is a fast-growing cancer of the blood and the bone marrow that affects lymphocytes, which is a type of white blood cells. It is the most common cancer in children, but it also affects adults, especially people over 50 years of age. So the age distribution that you see here shows a large peak in childhood and a second smaller peak after the age of 50. So treatment for childhood ALL has become one of the great successes of modern oncology, thanks to carefully designed multi-drug chemotherapy regimens. However, treating adults with ALL remains more challenging, and new treatments are still urgently needed. This year's ASH meeting highlighted three areas I want to focus on. The one concerns what we refer to as minimal residual disease, and that really means detecting very small amounts of leukemia that persist after treatment. The other is new drug antibody combinations for patients whose leukemia comes back after chemotherapy. And the third and most promising concerns the genetically modified immune cells, the CAR T cells, a promising approach that can go beyond chemotherapy. Change slide, please. So we're going to start with MRD. MRD refers, as I mentioned, to the tiny number of leukemia cells that can remain after treatment. Cells we cannot see under a microscope, but we can find with sensitive molecular tests. Now, MRD matters because it helps guide treatment. People with measurable residual disease after initial therapy often need more intensive treatment, while those with no MRD may continue with a standard plan. So this year's meeting, a study by Maroon and colleagues, compared two kinds of tests. A lymphocyte-specific test, that's called clonoSEQ, which looks for the exact leukemia fingerprint in the bone marrow, and the other, which is a mutation testing focused on the BCR-ABL1, which is a genetic change associated with some leukemias. Now, what the researchers found was that the results sometimes don't match, and the most common pattern of irregularity was a negative lymphocyte-specific test, but a positive mutation test. Importantly, none of the patients who were negative by clonoSEQ experienced disease recurrence, and this suggested that the detectable mutation alone does not necessarily mean that the leukemia will come back, and that the mutation may be present outside the leukemia cells. And the take-home message is that we should use the lymphocyte-specific MRD testing to inform treatment decisions. And if a mutation like BCR-ABL1 is still present, clinicians may continue mutation-targeted therapy, but results should be interpreted in the context of the MRD testing. The other interesting topic was drug-antibody combinations after chemotherapy. Change slide. Now, antibody-drug conjugates are an exciting class of medicines. They use an antibody to deliver a powerful chemotherapy agent directly to cancer cells. In ALL, one such antibody is inotuzumab, abbreviated as INO, which binds to the CD22 molecule on the surface of leukemia cells. Now, venetoclax is a small molecule drug that affects the mitochondria. the cell's energy and death control center, to turn on the cell's programmed death pathways. Venetoclax is well known in other blood cancers as AML, as you heard, but it is not commonly used in ALL. Now, a team from Dana-Farber, led by Dr. D'Angelo, combined venetoclax and inotuzumab in patients whose ALL had relapsed after chemotherapy. They tested 23 patients, and the results were remarkable. All the patients showed response, but 22 out of 23 patients had complete elimination of detectable disease. More than half of these were able to proceed to bone marrow transplant and achieve a positive result. Now, why does this matter? Because combining targeted drugs with antibody-drug conjugates can be highly effective even in challenging relapse disease. These combinations may offer new options for patients who have limited choices after failing chemotherapy. And the last brief part I want to update you on concerns the genetically modified immune cells, the CAR T cells. Let's change slide. Now, our immune cell, as you may know, is designed to recognize and eliminate foreign or abnormal cells, like bacteria or other pathogens. Cancer cells are supposed to also be immunogenic, but very often evade immune detection. So the CAR T-cell therapy is based on the notion of engineering a patient's own immune cells in the lab so that they can recognize and kill cancer cells. So what we do is equip our immune cells with this chimeric antigen receptor, which is able to identify molecules on the surface of the leukemia cells. Apologies, same slide. This is a brief overview of how we produce CAR T cells. We first isolate the immune cells from the body of the patient. We take them to the lab. We give them this antigen receptor that I mentioned. In parallel, we give therapy to retain the disease in control, and even a bit of low-dose chemotherapy to make space for the new immune cells to function, and then refuse them back into the patients. We monitor for adverse events, and then we evaluate for response. So several studies were presented at us and highlighted two important advances. The first was a study presented by Gu and colleagues, where they used CAR T cells in newly diagnosed B-ALL patients who had responded to therapy in order to deepen the molecular response that had been achieved. So they tested this notion in 35 patients, and 14 of whom had minimal residual disease positive findings. So they had some level of detectable disease. And instead of going through the multi-year-long standard protocol of intensive chemotherapy, they gave them one shot of CAR T cells. The results, although relatively early, are very striking. All of the patients had negative minimal residual disease after the infusion of the CAR T cells, and 1 year after the infusion, all were alive and disease-free. And this suggests that CAR T cells can deepen remission early in the course of treatment. Another very interesting study was presented by Dinofi and colleagues in a different setting. Here, these researchers used CAR T cells in patients with leukemia recurrence in their brain or spine, what we call central nervous system, which is a very difficult clinical scenario. They enrolled 43 patients, some of who had relapse only in the central nervous system, some others had in the blood and bone marrow, and enrolled them in the study with CAR T cell therapy. So all of the patients showed initial response. All of the patients cleared leukemia from the central nervous system. A number of them pursued additional therapy as a bone marrow transplant to deepen the response that was achieved with CAR T cells. But after 4 years of the conception of the study, the majority of the patients are alive and disease-free. This is especially encouraging because existing options for CNS relapse are limited. So all of this data suggests that CAR T cell therapy continues to show powerful leukemia effects and may be effective in difficult situations where traditional treatments fall short. And change slide. And to summarize all the data that I presented to you, we would say that lymphocyte-specific MRD testing is the most sensitive tool we have and should be used to guide treatment decisions. Antibody-drug conjugates combined with small molecules such INO and VEN show promising activity in patients whose leukemia has returned after chemotherapy and may allow some patients to proceed to curative transplant. And the genetically modified immune cells, the CAR T cells, are increasingly effective. They can eliminate disease and deepen remission, and they show activity in challenging clinical scenarios like CNS relapse. And that is all. Thank you for your attention. I'm happy to answer questions.
Thank you, Dr. Papaioannou. Very exciting data that you presented here. And Next, I'd like to introduce Dr. Jun Choi, who's a clinical assistant professor of medicine and a part of the leukemia team. His primary focus is in myeloid neoplasms, particularly MDS and MPN. He also treats a precursor of blood cancers, such as clonal hematopoiesis of indeterminate potential, also called CHIP, emphasizing the importance of monitoring and treating precancerous conditions as well. He's an investigator of clinical trials involving various types of myeloid blood cancers, including MDS, myelofibrosis, and AML. And today he's going to discuss many of those myeloid neoplasms. Please welcome Dr. Choi.
Hello, thank you for the opportunity to talk. So I'm going to present three different cancers. So I'll focus on some of the studies, but we'll be really just highlighting the important results. And I mainly highlighted in the red outline. So try to focus on that part of each slide. So first we'll go over MDS. Next slide. So just a brief review. So what is MDS? It's a group of blood disease or blood cancer that's defined by ineffective blood production. So you can have low red blood cells, which is most common, which is called anemia, low white blood cells and platelets, or any combination of those three. And that can lead to various symptoms such as fatigue, infection, and bleeding. And some of them can be indolent, but some of them can turn into aggressive conditions such as leukemia. So largely MDS is divided into two categories. One is low risk MDS and the other one is high risk MDS. So low risk MDS is a more slower disease, and symptoms usually arise from low blood counts such as anemia, low white blood cell and platelet counts. And the treatment goal here is not to treat the disease itself, because many patients can live long enough without any progression. So it's really to improve quality of life by improving blood counts. And these are some of the treatment options. And as it shows, some patients may not need treatment for a long time. And high-risk MDS is a different beast. It's closer to acute leukemia. It has a faster progression. And the treatment goal here is to treat the disease and alter the disease course and hopefully prolong survival. And treatment options are not a lot, and it's very similar to AML. That's why I'm gonna focus on lower risk MDS on this talk. So one medication that's new that was presented in ASH conference was elritercept. So how MDS, one of the mechanisms of actions that MDS lead to anemia is there is a protein group called TGF-beta superfamily. So when this pathway is activated, this can lead to ineffective erythropoiesis or underproduction of red blood cells. So what this drug does is it binds to all the ingredients that target and activate this pathway, thereby eliminating the activation of this protein, hence resulting in normalization of blood making process inside the bone marrow. So in this diagram is basically eliminating the ligand that binds to this pathway receptors. And there is one medication already approved similar to this drug, but this is basically more refined second generation version of medication called luspatercept, and it has a broader binding targets. So this basically shows that this was relatively safe and well tolerated, highlighted in the red outline. So grade 3, which is more severe side effects, were rare. That's elritercept related. Other ones are related to MDS itself. So it's fairly well tolerated drug. And main outcome, how they measured it, is measure the percent of patients who were able to achieve transfusion independence. So these patients required red blood cell transfusion heavily, often more than 4 every 8 weeks. And 40% of these patients were able to achieve transfusion independence after 24 weeks of using this drug. And that was the case also for high burden transfusion dependent patients as well, which is a pretty remarkable finding. And it did work pretty fast. Average time for it to work was 0.4 weeks, and it did last. It has a pretty long duration of response, about 2 years almost. And what was interesting was, unlike the predecessor medication, this one also had an improvement in white blood cell or neutrophil as well, on about 30% of the patients, as well as platelet counts, which was not really seen before. So this was a very interesting finding as well. So overall, this is a pretty effective drug for lower risk MDS patients, improving blood counts, especially anemia, but also with white blood cell and platelets. So I'm going to quickly go over to the other medical condition called MPN. So this is a condition where opposite happens. So it's too many blood cells are produced. And three prototype conditions is polycythemia vera, which is too many red blood cells, essential thrombocythemia, which causes too many platelets, and myelofibrosis is basically the more advanced version of these two, where bone marrow cells become more fibrous or scarred up and leading to various symptoms. So first I'm going to talk about polycythemia vera. Next slide. Which is a condition where too many red blood cells are produced in the bone marrow. And this can lead to increased risk of clots, such as heart attack and stroke. And the goal here is to keep that red blood cell count under 45% hematocrit. So one interesting new medication is called Lusfertide. So what this does is it prevents iron from being exported into the bone marrow from the spleen and the liver, where all the iron is stored. So it takes away the ingredients for the bone marrow to make red blood cells, hence preventing overproduction of red blood cells. Next slide. And this was a phase 3 placebo-controlled trial. So in patients who received lusfertide, as you can see in the blue line, the hematocrit was very well controlled up to a year. But in placebo group, the hematocrit quickly increased, and by 32 weeks, they were able to cross over to receive lusfertide, and quickly the hematocrit went down to normal level. So in conclusion, most patients were able to achieve good hematocrit control without needing physical removal of the blood with phlebotomy. And lusfertide did this without exacerbating any symptoms of iron deficiency, which can also be pretty debilitating. And lastly, I want to touch on myelofibrosis. So myelofibrosis, main issues with myelofibrosis is symptoms. So this condition, again, is more of an end-stage condition of MPN where bone marrows are scarred up. And that can lead to various symptoms, increased inflammation, and symptoms such as fatigue, weight loss, night sweats, increased spleen size, resulting in abdominal pain and decreased appetite. So the treatment goal here is to really decrease the inflammation and the size of the spleen. And there is a new medication called BET inhibitor. And this leads to decreased inflammation and it is shown to reverse the fibrosis of the bone marrow itself. So here, when NYU was one of the medical centers that participated in this trial, so by 24 weeks of drug, this medication by itself, 43% of the patients who were able to receive the proper dose of this drug were able to achieve spleen size reduction by 35%. And about 46% of these patients, we also measured the symptom control. They were able to report that they achieve more than 50% of symptom improvement, which is our ultimate goal. And there was, it wasn't shown in the slide, but there was also improvement in the fibrosis or scarring of the bone marrow itself. So this is being tested in the next phase larger trial and with another type of a BET inhibitor. So this looks like a promising drug, whether in monotherapy or in combination with a standard therapy. So this is an exciting next new chapter in this condition. And this is my email. If you have any questions, I'm happy to answer.
Thank you, Dr. Choi. And I know you described the BET inhibitors and you've led some of these trials with these agents here at NYU. And I want to thank again our leukemia experts for the wonderful data that they presented. And much of you all were part of much of the research that is now presented at national and international conferences. So without further ado, I'm going to welcome Nicole Fortoso, who's a patient and community outreach manager for Blood Cancer United, formerly known as the Leukemia and Lymphoma Society. Nicole has a background in social work and works to connect underserved communities with education, resources, and support related to blood cancer care. Her work focuses on health equity, community partnerships, and empowering patients and caregivers through culturally responsive programs and outreach. So welcome, Nicole. It's a pleasure having you tonight.
Yeah, thank you so much. As Dr. Lahoud mentioned, the Leukemia Lymphoma is now Blood Cancer United. We went with our name public around September, and really the whole reason for this name change is to make sure that all blood cancer patients feel included in our name. And we also found that a lot of folks thought because the name was society that they had to pay some sort of membership to benefit from our resources and education when we really want to promote that they're all free and available to all blood cancer patients and caregivers. Again, my name is Nicole Fortoso. This is my official title and my phone number and email. Please feel free to reach out with any questions after this presentation. The mission, and we've had this mission for quite some time, cure blood cancer and improve the quality of life for all patients and their families. This is a screenshot of our new website. If you type in lls.org, it will direct you here, so no hard feelings there. But just in case you do want to know, this is what it would look like. First, to promote, our blood cancer conference is happening March 14th of this year in Times Square. We're really excited. This is a great way for patients, caregivers, and healthcare providers to connect and get to know their blood cancer community in New York and in the tri-state area. These are also some of the resources that we offer to healthcare providers, free CE and CME in-course, in-person region rounds. We do have one coming up, I believe, February 11th, so that will be listed on our website. It's an in-person CE credit opportunity. If there's one thing you take away from our resources, I hope you take away our Information Specialist Resource Center. This is a number. This is the real experts when it comes to blood cancer diagnosis, resources, education. They provide it all. This is kind of your one-stop shop. You can get one-on-one personalized support about blood cancers and ask all the questions from financial support all the way to medical questions as well. We also have our clinical trial support system. This is another support that we have where you can work one-on-one with an LLS, now Blood Cancer United, clinical trial nurse navigator who will actually talk through all your clinical trial questions, whether they were presented to you by your medical team or if you want to explore additional options, they can guide you through that process as well. We also have free nutrition consultations available. This is a 30-minute free consultation with one of our nutritionists and dietitian. I do like to say that our nutritional services are available to all cancer patients, not just blood cancer patients. This is one of our support programs that we have. Our First Connection program is actually a peer-to-peer program that we have. We find that a lot of folks would really like to connect with someone who's gone through a similar treatment, who's gone through a similar diagnosis, or frankly, sometimes we find that there's parents who have been diagnosed and want to know what it's like to go through treatment while being a parent to young kids. And this is an opportunity for you to connect with someone one-on-one. It guarantees a one-time phone call, and we find that a lot of our volunteers and requesters actually stay in contact because they built a meaningful relationship connecting with someone who's been through the same thing. This is one of our other platforms, our patient community. This is what we like to call our Facebook of sorts. So you're able to connect with other folks and have different posts that go about different things. So we have one that's really just about being positive through treatment. There's one that talks about certain treatment plans, what it's like to be in survivorship. So all these options are available through somewhat of a Facebook platform. To emphasize again our support programs, we do have family support groups through Blood Cancer United here locally in New York. Most of our support groups are virtual, but they are available and they're listed on our website. There's a link to that. Our online chats, again, this is something that's monitored by an oncology social worker. So this is a good way to connect with other folks going through a similar experience, and it is monitored. So there won't be anyone talking crazy on it because it is going to be monitored through oncology social worker. And then our caregiver support, we do offer a number of resources for caregivers, including our workbook and online chat that is just primarily for them. And all these programs are also available to patients who are, all the programs that are available to patients are also available to caregivers. This is a few of our financial support programs. A lot of these programs are on an open and closed basis, and you can apply on your own, or you can have your medical team apply for you. The only one that you need a healthcare provider to apply on your behalf is the Urgent Need Program. Other than that, you're able to apply to the Copay Assistant Program, Travel Assistant, and the CAR T-Cell Travel Assistant Program, all through our website or by calling the Information Resource Center. Our medical depth case management program is one of our new programs. What I really love about this is although it's to to talk about medical depth that you're currently in, it's also a great option to talk through how to prevent it. So if you're newly diagnosed and you're worried about what that's going to look like with your current insurance, you're able to talk to one of our medical depth case managers and talk through what options you have before you get the bill. And it's a really great resource. Next slide, please. These are free educational booklets and fact sheets. These you're able to download and to get a physical copy sent to your house. What's really great about this is that they're available in English and in Spanish, and we find that these are great resources that are up to date on anything that you may have questions regarding, such as your diagnosis, managing stress, food assistant, and other resources. This is another way to continue your learning with us. So if you have additional questions, you can read our educational booklets and fact sheets. We do have webcasts and podcasts available online as well. A lot of heart goes into these, so I highly encourage you. There's conversations and podcasts anywhere from managing stress, treatment, you name it. We probably have a podcast on it. There's also available videos and, as I mentioned, our podcast also available. These are some ways to get involved. We highly encourage folks to volunteer with us. As I mentioned earlier, our peer-to-peer First Connection program is a great way to do it. Not only if you're looking for someone to get partnered up with, but if you feel like you're a year out from remission and you would love to share your experience with someone, we highly encourage you to volunteer with our First Connection program. You're also, please, we love hearing your stories. You're able to do that as well. And you can also join a campaign with our incredible campaign team here in New York, and I'm happy to connect you with them as well.
Thank you, Nicole. That was a great presentation. And next, I'd like to welcome the most important speaker of the day, Kartina Chu. Kartina is an acute myeloid leukemia patient and a bone marrow transplant recipient. She's here to share her personal journey with leukemia and the strength that she's found along the way. So welcome, Kartina, and please tell us a little bit about you.
Hi, good evening. My name is Cortina. And before I tell you anything else, you should know this. I had absolutely no plans to be on a platform like this talking about leukemia. Before September of 2024, I had a full life. I had work I loved, people I cared deeply about, and plans I fully intended to keep, including travel plans already booked. In fact, I booked the flight just 1 week before I was admitted to the hospital. My suitcase was basically always half packed. Life felt honestly pretty much perfect to me. I like to joke that if someone had bet $1 million just a month earlier and said you have cancer, I would have confidently taken that bet, lost $1 million, and still end up with cancer anyway. A true lose-lose situation. Then, after what I thought would be a routine emergency room visit to NYU, I was even telling my friends, it's no big deal. I'm just going to the emergency room to get my fibroids removed. However, I was told I had acute myeloid leukemia. I don't remember every medical detail from that moment, but I remember my heart dropping straight to the floor. I remember trying to protect my mother from hearing the words. I remember wanting to go home, just hug my dog and pretend none of this was real. Instead, within an hour, I was admitted to KP18, and just like that, my life changed. Treatment is often described in protocols and timeliness, but living it is very different. It's long days of waiting, it's losing control over your body, and waiting for it to recover just enough for the next round of chemo. It's trying to stay hopeful while your life becomes measured in lab values, infusion schedule, and appointment times. It's learning a kind of patience you never wanted and definitely never asked for. There were many days of doubts, but early on, I made a decision. Cancer was not going to take my identity. I was often reminded that I should take days off, but I didn't, not because I was ignoring reality, but because I didn't want leukemia to control my life. I wanted to keep living, keep working, keep moving forward, and deal with cancer on the side. I didn't want pity to take up space, and I didn't want to sit in the question, why me? Because I knew I would never get an answer, and I wasn't going to let cancer write that chapter for me. In fact, I may be the first person ever to be on a work call while getting a biopsy. I'm not entirely sure, but I'm pretty confident saying I'm here just breaking clinical records. What surprised me most during this journey was how much the way care was delivered mattered. I remember the first day I met Dr. Hay. He told me this was curable. At a moment when all I had were doubts and tears in my eyes, I felt like my life was ending. But hearing that one word didn't erase my fear, but it gave me something to hold on to. Since then, I've made it my personal mission to keep Dr. Hay on his toes. I regularly challenged him and asked him one very important question. So, when can I get back on a plane? Now, the nurses, nurse practitioner, and physicians at NYU never doubted me, even on days when I doubted myself and giving up felt like the easier option. They didn't just treat my disease, they treated me. They spoke to me as someone with a future. When I was tired, they were steady. When I was afraid, they were reassuring. And when hope felt far, far away, they kept it until I could carry it again myself. In those moments, didn't change my diagnosis, but they changed my experience. They gave me dignity when I felt vulnerable, and they gave me strength when I felt depleted. And they reminded me that science and compassion are most powerful when they work together. In October of 2025, I became a bone marrow transplant recipient. I'm profoundly grateful to my donor for their generosity, their selflessness, and for giving me a second chance at life. This is a gift. This is something I carry with me every single day, and it reminds me just how much hope still exists in humanity. Today, I'm still on this journey. I'm not standing here to say it's easy or that it's over. I'm standing here because I'm still here and because science, trust, and an extraordinary medical team made that possible. For any patient who may be listening today, there will be, days filled with doubts and what if. That doesn't mean you're weak. It means you're human. And on those days, trust the science, trust your medical team, and remember that you don't have to lose who you are to survive this. Cancer may be a part of your journey, your story, but it doesn't get to be the whole story. The science saves lives, compassion sustains them, and hope, real grounded hope, keeps us moving forward. Thank you for walking along patients like me. Thank you for believing in us, even when we struggle to believe in ourselves. And thank you for giving people like me not just more time, but a future worth stepping back into. Thank you.
Thank you so much, Cartina. It was a very touching testimony, and I found it very inspiring, but also encouraging. You know, um, patients with leukemia often feel defeated. As you said, it's not something that you planned for, and nobody really plans for that diagnosis. But thanks to the great care of Dr. Abdul Hay and all the team, where we have the privilege of welcoming you on our panel today. Um, well, a lot of questions have come in the chat. We try to answer as many as possible. There's like for another question, but thank you, Cartina, for sharing your story. You're an inspiration, and you will get back on a plane one day. Exactly. That's why we do this.
It's every question with Dr. Hay. Every week I see him.
Hopefully in a few months.
He keeps me grounded. He keeps me grounded.
Wanted to ask a question actually for Dr. Abdul Hay, if he doesn't mind. So you presented the paradigm study, and now, so is there still a role for chemotherapy backbone in acute myeloid leukemia induction? The old name 7+3.
So that's a great question. So as I mentioned when I present the paradigm, that people that have FLT3, NPM, core binding, they were excluded. pH positive, they were excluded. So I think those patients should still be getting induction chemotherapy. Now the downside of HMA venetoclax is if you take a look at the study and the curve, they always goes down. It always keep going down. So it's not unfortunately curative, and all these patients, most of them, they need transplant. The advantage of sometimes like younger people to induce them with 1, 7, and 3, you can get them into remission right away, and you have your take them right away to transplant. But back to your question, I think in this era, more and more we're going to see HMA venetoclax up front, even in young, healthy, fit people, because the data look so compelling. Look like it's if it's not as good, it's probably better. And you have less toxicities, and you probably can take them for transplant because you have less toxicity, so they'll be ready for transplant. I think that paradigm is going to shift, and I think more we're going to be doing HMA Ven instead of 793 and Vicious.
Thank you for that. For Dr. Choi, I know you only had limited time, but no, anything novel with CML that you could you could tell us about that you've heard during ASH.
Yeah, there are actually two new class of drugs in CML that are being developed. It doesn't really have a name yet. One is Enliven and the other one is Turn. They are basically improved versions of what we have, which are the TKIs and Semblix. So this just means that we already have 4 or 5 options already. And down the road, I think we'll have a couple more. And NYU is actually, in the next few months, will be opening a clinical trial on another great drug in someone where standard therapies may not have worked. So we'll be in touch with all the patients about this clinical trial.
Thank you. And Dr. Papaoianu, I have a question for you.
Please.
Because that's your research interest. Um, TP53 mutations.
Yeah.
What can we do to overcome that struggle in pretty
I-
much
I-
any
I-
malignancy,
Yeah,
but any leukemia?
yeah, no, it's a very interesting question. It's interesting because we're still trying to answer it. I think it will be a while before we actually have an answer. One has to say that there is a leukemia context where we have been successful in finding a treatment, and this is the prudent tyrosine kinase inhibiting drugs in CLL, where TP53 loses its bad prognostic effect, and I think that's why. There is room to to be optimistic that there will be an answer to that. My personal belief that is tailored immunotherapies and what we call peptide-centric CAR T cells might provide an answer. In the previous ASH, there was a whole session about TP53 and the potential use of hypomethylating agents as maintenance therapy post-transplant. And there was potentially a signal. We are waiting for more mature trials to show that this is the way to go in TP53 mutated. Well, there are things we can do. Of course, allogeneic bone marrow transplant is what merits as an answer to that, and things that we can try to tweak to optimize outcomes. But I think in the near future will hold more hope.
Dr. Abdul Hay, you mentioned that study on your FLT3 targeted bispecific antibody, yet FLT3 expression, uh, I mean, it seemed to work regardless of the status of patients. Why do you think that is?
Right. So because myeloblast actually more than 80% of myeloblast express high FLT3. So it's a target regardless if you're FLT3 mutated or not. And actually most of our CR were I mean we saw in both FLT3 and FLT3 wild type and mutated, but we saw more in FLT3 wild type actually. And this is single agent. You're seeing about 1/3 CR for people that have failed up to 8 lines. And especially in P53 mutated patients, we're seeing 50%. And P53 is extremely difficult to treat. So it looked like a very attractive compound with very low toxicities. And what I'm very excited about, not just that now we're going to dose expansion, we're trying to put it on an earlier line in combination with chemotherapy. I think it have a lot of potentials.
Um, any potential for FLT3 targeted CAR T cells in this case?
You know, no one have been exploring that, but because of the TKIs we have in FLT3, but now we have showed with a BiTE, you could probably target FLT3 even in wild type patients because it's highly expressed and you can have response. So I'm not sure if the future will have a CAR for FLT3.
And Dr. Choi, you didn't get to present any data on it, but how about clonal hematopoiesis? Do you have a feeling that we could just prevent this myelodysplastic syndrome or acute leukemia from happening if we're able to identify people at risk before? and treat them.
Yeah, I think that's where the field is going. There are a handful of trials around the nation where we are using some targeted agents a little bit early on. So main one was IDH inhibitor. There's a trial where high risk clonal hematopoiesis patients did receive this and was able to improve their cytopenias. Now, it is a sort of a chemotherapy, so our goal here is to try to use something less toxic, something like there are trials using statins. There are trials that I think will be promising that will use something like colchicine, which is a pretty benign drug, but has a potential to prevent progression into actual cancer. So that's an exciting area, and I'm hoping to open some trials in that area as well.
I know you didn't get a chance to cover it today, but how about T cell ALL?
Yeah, there were not a lot of data in the adult population. Was most of the things that were presented concerned the pediatric population. There was one oral presentation about it. We did speak for improved data for improved efficacy with dose escalated chemotherapies in the patient population. TLL, we have to say the one aspect where it lags behind from the BALL is the fact that we don't really have very good CAR T cells other than the product that we mentioned that is currently in clinical trials. That really is affecting outcome.
I'd like to again thank Katie Grace for putting these together, this series together. Dr. Abdul Hay, Dr. Papayoannou, and Dr. Choi for reviewing the wonderful data and exciting promises that are emerging in leukemia treatment that were presented at ASH. And last but not least, Nicole and Cartina for being such excellent patient advocates. So thank you to all people who attended. It's been a great session and looking forward to more exciting discoveries in the field.